Okay, I'd like to thank you all for taking the time to come today. You're at the joint replacement class. My name is Jan Vandermolen, and I'll be conducting the class today. And very importantly, we'd like to thank you for choosing the University of Chicago Medicine for your medical care and allowing us to be on this journey with you for your joint replacement. The class will be following the syllabus that you have in front of you. It'll also be on the screen as a PowerPoint. If you have any questions while I'm talking, there are spaces on the syllabus that you can jot your questions down, and I'd appreciate it afterwards. You come and ask me all those questions. Do not leave today until you have those questions answered. This is part of the team that you'll be seeing while you're here in the hospital. Dr. Liu is a hip and knee replacement specialist that also has a dual interest in bone reconstruction for cancer people. I am Dr. Liu's nurse. We actually have another orthopedic surgeon here. It's Dr. Rehab. He does knee replacement surgeries, and he has a dual interest in sports medicine. And his nurse is Jennifer Lawrence. We both feel that if you have any questions in the process towards your joint replacement, call us. We like to say, if you're concerned, we're concerned. Call us and ask us. In the packet that you received in the mail, there was a little checklist. And I'd like you to be working on that checklist as you progress with your joint replacement surgery. It gives you things that you should be doing ahead of time, and then just keep following that. And we will be talking about different items on this checklist during this talk today. I'm going to give you a brief lesson on anatomy. This is a knee replacement. This is the big femur bone that goes up on your thigh. Down here is your tibia and fibula. And in the middle here is your knee joint. And in the middle here is cartilage or meniscus. And this is what your bones actually are cushioned with. This is what prevents that pain. When you need a knee replacement, this is the part of your knee that's been destroyed, or there's something wrong with it. So you're no longer having a cushion in between your bones. And the same thing with the hip replacement. This is the femur bone. This is the big bone on your thigh bone. This is what we call the head of the femur. And this fits right into the pelvic area. And in this pelvis, you'll have that meniscus or that cushion. And once again, that's what prevents the pain when you have bone on bone. And when you need a hip replacement, the cushion here or the meniscus is what's destroyed. There are certain reasons for joint pain. Degenerative disease, bone on bone, or destruction of cartilage. And they're all the same thing, talking about the same thing, just different ideas, a way to say it. This is an x-ray of an arthritic hip and a normal hip. If you see the hip on the right side, you can see how round the head of the femur is. On the other side, you can see that it's kind of diffused, and you don't see a nice round head. Kind of another look of arthritic and normal hip. And the same thing is with a healthy knee and arthritic knee. The one on this side is a normal knee. You see some space in between there, which is not actually space. That's actually your cartilage or your meniscus. And that's not picked up on x-ray. So it looks like space, but the one on this side has some nice healthy space or meniscus. The one on the other side, you can see the femur bone is grinding into the tibia bone. The meniscus there is destroyed, and that's where you get bone-on-bone pain. Some of the reasons for the cartilage destruction or the meniscus destruction is past history of injury. A lot of my patients will say they had an injury when they were a child, when they were playing ball or something, and it wasn't even manifested till years later. Just because there is an injury, it doesn't mean you're going to have arthritis, but a lot of times they can pinpoint a time in their life where they had quite a significant injury. Medications can also cause destruction of cartilage, especially people who are on high doses of steroids, people who take steroids for asthma. A steroid is a medication that actually is a life-saving medication, but it also has a potential to destroy cartilage too. And once again, just because you are on high doses of steroids for a long period of time, it doesn't mean you're going to have a replacement, but there does seem to be correlation between the two. Another one is avascular necrosis, which is just a decreased blood flow to the joint. Rheumatoid arthritis is another disease that affects all the joints in the body. And that's when you see a rheumatologist and he gives you some medications for that. The most common disease that affects cartilage is osteoarthritis. And osteoarthritis can affect one joint or it can affect many joints. And I have read all kinds of literature. There's no predictors about if you have osteoarthritis in one knee or one hip, you're going to have it in any other ones. There's no predictor. So you could just have it in one knee and not get it in the other hip. But there does seem, or other knee, excuse me, but there does seem to be some kind of path that it does show in both knees or both hips. And there also seems to be a genetic component to it. A lot of my patients will say, my mother had a hip replacement. My sister just had her knee replaced. So there does seem to be a genetic component, but once again, studies can't directly correlate that. So what do we do when you come to Dr. Lou or Dr. Athavaraham? The first thing we'll probably ask you to do, try anti-inflammatory medications. Now, anti-inflammatory medications are medications that do not affect the cartilage, but because there's fluid that's produced in your hip or the knee, it makes your knee feel tight and swollen. And so these anti-inflammatory medications take away some of that fluid to produce less pain. It has no effect on the cartilage, but it does take away some of that fluid to make your knee feel better. I think especially some of the knee patients, they say, my knee feels so tight. And that's just the fluid that's produced. And because we're asking you to take Aleve, Motrin, ibuprofen, those are all medications, and if they don't help anymore, we ask you to stop them. We never advocate taking medications if they're not working. And then the next step we have is injections or shots, whether it's in your hip or in your knee. And those can be done every 3 months for as long as they work. And once again, those are anti-inflammatory, does nothing for the cartilage, but it takes away the fluid to make the joint painful. So you can have those as long as they're working, but once again, once they're not working, doctor will say we need to talk about the next step. It's a medication, and we never advocate continuing with something that doesn't work. And then the third step is surgery, which is why you're here. And your doctor will discuss the different forms of the surgery and what's the best for your particular disease. One thing you need to know about joint replacement surgery, it's optional or elective procedure, which means you never have to have it. It's not life-saving, but we really feel it's life-changing. And so we'll talk about different things. So it's an optional procedure. Your family cannot say you need to have this. Your minister, your neighbor said, oh, I had it, just go ahead and have it. It has to be a very personal decision between you and your doctor. What is best for you? So it is an elective procedure. And a lot of my patients say, well, Jan, when shall I have this procedure? And there are different things that I ask you to consider. One of them is your life being changed by this painful hip or painful knee? You're saying no to things that you used to enjoy, such as going to church, restaurants, out with your grandchildren, taking walks, theater, because it's very, very difficult to drag a leg around that is always in pain. So that pain is just always there. And it's changing your life. It's changing the things that you like to do. So is your life being changed? Maybe it's a time to start considering it. We also talk about work situation. A lot of the people who are having joint replacements now are younger, and they are still working. We ask your employer, for 12 weeks off. We usually can send you back earlier, but it's better for us to give them the outside time than to give them a shorter time and ask to send you back earlier. So about 12 weeks. So make sure your employer knows what's going on. The University of Chicago also has a care partner program, and that's probably something that's in your packet when we mail to you, which means we want to take this journey with you, but once you leave us at the hospital, we want to make sure that there's someone there who's going to help you. So we'd like you to identify a care partner. Who's going to maybe make a meal for you, provide transportation, just give you pep talks if you need it. So we'd like you to identify a care partner in your life. And then last of all, then you have discussed all this with the doctor, it is major surgery, and we have to make sure that the benefits outweigh any of the risks that come with any major surgery. One of the first risks that we talk about is infection. The University of Chicago is very concerned with that. The national average of joint infections is 2%. Dr. Athavaraham and Dr. Liu have it down to about less than 1%. So we do take it very, very seriously. An infection in your joint could possibly mean we'd have to take the joint out and put it back in at a later date. It's usually like 6 to 8 weeks. So that's a possibility. If it becomes infected, we may have to take it out and put it back in later. So an infection in your joint is really a catastrophic event. So like I said, Dr. Liu and Dr. Athavaraham are very concerned about infections. So what do we do about that? The first thing we do, we have you see a dentist. We know that our mouth is the dirtiest part of our body, so we need to have a dentist look at our mouth and say there's no infection, there's no decay, everything in there looks good. And then you can proceed with the surgery because the dentist will fax over that clearance and will know that that's one less concern that we have. The dentist has cleared you. Now that dental treatment and dental procedure is a lifelong commitment. We need you to see a dentist every 6 months for the rest of your life. And before you step into the dentist's office, you need to take an antibiotic. And we will supply the antibiotic or your dentist will. It's just one dose an hour before you see the dentist. Now the Dental Association actually came up with these recommendations, but they've backtracked. They say no, only 5 years after your replacement. Dr. Athavaraham and Dr. Liu feel very strongly about lifelong. So it's one dose an hour before you see the dentist every 6 months. Bactroban. Bactroban is that crazy ointment that I asked you to pick up. There's a prescription in your packet that you need to go to the pharmacy, pick it up. It's an ointment that kind of prohibits infection to go to the rest of your body. Our nose is kind of the functioning of a filter, so when we breathe things in, some of the bacteria gets caught in our nose hairs, and so that antibiotic ointment will kind of take away that risk. So that's the Bactroban. You'll use that ointment on a Q-tip, put it in your nose twice a day for 5 days prior to surgery. Another arsenal that we have in our arsenal are the surgical wipes. These surgical wipes have been developed by the University of Chicago infectious disease people. There are 3 in a pack. The night before surgery, you'll take 2 of them, and you'll take a shower and wipe your whole body down with these 2. Not your face or genitals. Have someone in your family help you with your back. Should be an all-body thing. The morning of surgery, you take the 3rd one, and you'll do just the knee or the hip that doctor's doing surgery on. Now, Dr. Athavaraham has a different procedure with these. He would like his patients to use these for 5 days. So if you're a Dr. Athavaraham patient, it's 5 days. If you're a Dr. Lou patient, it's the night before and the morning of. And if you did not receive these yet, just come and see me after class, and I can give you one of these. So like I said, the lifelong caution about dental care, bacteria infections, and wound care. Now, if you would have a cold or a sore throat or an earache or even a toothache, you need to see your primary care doctor. If you have a fever, that may be a bacterial infection. And this is a lifelong commitment. Always have that in the back of your head. Oh, I had a really high fever and I had an earache. We always worry about that bacteria going to the knee replacement or the hip replacement. Because what happens is when we have bacteria in our body sends blood and washes it out and cleans it out. But when you have metal here, it's a lot harder for the blood to get underneath here. And if some of the bacteria gets harbored underneath here, it has a potential to become infected. So if you would have an infection, call your primary care. Tell them I had a knee replacement and I have a fever, I have a really sore throat. And if you have any concerns, you call me or Jennifer. Once again, if you're concerned, we're concerned. Please call. Now, if you would have an infection, say, 5 years from now, and that hip or that knee were doing just wonderful, and all of a sudden after the infection you've had a lot of pain, it's stiff, you have a little fever that keeps on, you should call us right away, because there is a small window of opportunity that we can wash out this area really well before we have to have something more final to take all this out. So once again, if you're concerned, give the office a call. So another risk for surgery are blood clots. And there are 2 blood clots that we're concerned with. One is a deep vein thrombosis, and the other one is a pulmonary embolism. The pulmonary embolism is a blood clot in your lung, and that is an emergent situation. For the first 3 weeks after surgery, if you would have any problem with deep breathing, you're coughing up blood, you just can't take a deep breath, you need to go to your local emergency room immediately. Don't call our office, just go to a local emergency room. There's a very simple test that they can take to see if you had a blood clot in your lung. Tell them you recently had some major surgery and you're having a hard time breathing. Now, the surgery you're having is below your belly, so you're going to have swelling in your legs. It's all part of the surgical procedure. You get some swelling. So you need to make sure that you elevate your legs as many hours of the day as you can. And when I talk about elevation of your legs, I mean higher than the level of your heart. So you need to draw an imaginary line from your heart to your leg, and your leg has to be higher than that. So if you're sitting in a chair and you have this wonderful, nice, soft hassock in front of you, I can guarantee it's not high enough. I always tell Dr. Lou that I think it'd be wonderful as a thank you gift. All our patients receive a nice lazy boy chair, you know, because the back goes back and the legs go nice and high. That's how high we need to have your legs, higher than the level of your heart. And you really can't do that enough during the day. If you're sitting in a chair visiting, watching TV, reading, make sure those legs are elevated. Now, if you call me and say, I cannot get the swelling out of my legs, and you promise me that you've been very diligent about elevating, then I'll have you come in because we may suspect a deep vein thrombosis or a DVT. And once again, that's a very simple test to determine whether there is a blood clot there or not. So if you take nothing else from my class right now, higher than your heart is the elevation. So Dr. Lou and Dr. Athavaraham, once again, take blood clots very seriously. So what do we do about that? First of all, early moving, walking around. If you are having your surgery early in the day, you will be walking around in recovery already. Because if you walk, you can feel that your muscles and your legs are the blood is being pushed through. So early walking Get those legs moving. Another thing that we do are ankle pumps. And you can do these in the hospital, you can do these at home. And what you do, you take your ankle and you pump it and you rotate it. Because once you do that, you can feel the muscles pushing that blood through your lower leg. Elevate your leg. And how high are you going to elevate your leg? Above your heart. Thank you. And then we also have TED hose, which are those white tight hose that we'll put on you. If there's swelling in your leg, doctor will actually order some that you'll take home. You don't have to wear them at night, but you do need to have them on during the day. But remember, they're very difficult to put on by yourself. So this is where your care partner will come in, take them off at night before you go to bed, and they'll help you put them on during the day. So the white hose. And then there are two medications that we use, Coumadin and Xarelto. Dr. Lou uses Coumadin. It's a blood thinner that you'll be taking for 3 weeks, and you need to have blood draws twice a week to make sure the dosage is correct. So you'll be on that for 3 weeks. Dr. Athavaraham uses a medication called Xarelto. That's also a blood thinner, but it does not require blood draws. But those, you'll be on that for 3 weeks also. And the last thing I want to talk about is for both the hip and knee replacement surgery patients is a risk of death. It's major surgery, but if you have gone to your anesthetic appointment, you know already that your primary care has to say okay to the surgery. Are you being treated for diabetes? Your diabetic doctor has to say okay. If you see somebody for your heart, they have to okay it. And then once all your outside primary care doctors have said okay, then you'll see the anesthesia people and they'll put everything together, and they once again will have a good physical, make sure you're in optimal health before Dr. Lou or Dr. Athavaraham will do the surgery. So all your doctors are the gatekeepers before a doctor will do the surgery. I'm just going to talk a little bit about 3 risks for people who are having hip replacements. Number 1, limb length discrepancy, which is a big way to say you feel uneven. Your new hip might feel a little bit longer, and that is something that will go away. Doctor does do all kinds of measurements to make sure everything looks level, and he will look at it, and usually at 3 months, if you're still having that feeling of being uneven, then he'll probably put a little lift in your shoe. But that's not something we're concerned about right away. Hip dislocation. There is potential for hips to be dislocated if you do the wrong thing, you make the wrong move. So your therapist will go over and over and over. This is what you can do, this is what you can't do. And the last thing is nerve pain. The nerve pain is for the hip and knee people because there's a lot of things going on. There's a nerve that could be kind of jostled around a little bit, and it would just be painful for a while. And that only happens to 1%, and it usually is temporary. Now we're going to talk about the parts of the prosthetic knee. There are 4 parts. This is the tibial component, the femoral component. This is shaved. The tibia is shaved and made this to fit right on here. This is the tibial component. Your bones are like chicken bones, so this goes right down the middle. And this is the plastic, or this is what takes the place of your meniscus or cartilage. And it fits right on like that. And then your kneecap, doctor will put a little backing on the kneecap just so it slides over here really well. So 4 parts to a knee replacement. There are also 4 parts to a hip replacement. Once again, your bones are like chicken bones, so this slides right down your femur. This is the head of the femur, and this is the plastic that fits right into the shell of the pelvis that your hip replacement rotates on. Now, when I talk to people about hip and knee replacement, they're like, well, you don't really take anything out of a knee. We don't. We kind of shave it and just form it, make it fit nice. But contrary to that, in a hip replacement, we do actually take something out. Doctor has to actually take the head of the femur off This is cut away because this is also bad for the cartilage and it bad for pain because it no longer is bearing the weight that you need to have. So this is cut away and this is put on there. So how does doctor know which knee replacement or hip replacement he wants to use? Because there are as many prosthetic knee and hip replacements as brands of cars. There's Biomet, Johnson & Johnson, DePuy, Smith & Nephew, Stryker, Zimmer. And if you watch TV, you'll find out a lot of those have been recalled, and you're always worried about that. But I want you to be assured Dr. Lou and Dr. Athavaraham have never used one that's been recalled. So how do they decide? Well, you had all kinds of x-rays taken before your surgery, and doctor does measurements and he looks at the bone structure to see which one works best for you. Dr. Athavaraham prefers the Stryker knee method. The Zimmer knee method. Dr. Lou uses the Stryker knee hip and knee replacement. And why do they decide that? Because usually it's something they've trained with. They like the instrumentation, they're used to it, they like the way it feels. But you need to know that if they do those measurements and they feel like something else will fit you better, they will go to a different product. This is not something that's on the shelf and they just pull it off the shelf to fit it into you. It's measured, it's looked at, and it's very conformed to your body. Getting ready for your hospital stay. Well, this is one point in getting ready. You had all your appointments. You come to the class. You have a care partner identified. You have your medications. And then I or one of the other nurses will call you and tell you what time to arrive the day of your surgery. And the reason I've dragged you all the way over here is because this is where you're going to report. You're going to report to the same 7th floor sky lobby. And I think that's one less fear that you'll have, then you'll know exactly where to come the day of surgery. And we'll let you know what time. The earliest you need to be here is 6 a.m. The latest is probably around 11 or 12, depending on where you fall into the schedule. And something else we want you to think about are your discharge options. Are you going to go home or are you going to a rehab? If you go home, we will send a nurse and a physical therapist to your home 3 times a week for 3 weeks. If you're going to go to a rehab, we want you to start thinking about where do you want to go. We always prefer you to go home. But that being said, we don't want you to go home to an unsafe place. So if you have no one there that can be helping you, then we will have someone talk to you about options of admitting somewhere. And that's usually Portia, our social worker. And Portia will discuss different places that you can go. And Portia's number is in the last sheet on your syllabus. So make sure you connect with Portia. If you're going to go home, we're going to set up a rehab, a home health care service come to your home. And we do have someone who's a specialist in that, and her name is Allison. And Allison will come and talk to you too about if you prefer someone. Allison works for ATI, and she will be present after the demonstration if you'd like to talk to her. And as I said, the work situation, you're getting ready. Your employer knows you're going to be off for 12 weeks. I want you to know that you are being admitted to a private room on 9 East, which means you have a bed in there for you and you have a bed for your care partner. So if your care partner wants to stay the night and just kind of hold your hand, that's perfectly permissible with us. It's not required, but if you decide that you'd like to have someone stay with you, that's fine. The patient orders meals anytime they want. There also is an option for your care partner to order meals. And if you're having a hip replacement, you're usually here about 1 night, and you can go home later in the afternoon of the next day or evening, early evening. If you're here for a knee replacement, you're usually here about 2 nights. And we ask your care partner to pick you up by 11 o'clock on that 3rd day. Some of the things that have happened while you're here is you're going to have a drain at your surgical site that will be draining fluids and taking away all that fluid that's accumulated. That drain will be put in during surgery and come out the next day. You're also going to have a Foley catheter that's put into your bladder to drain the urine, and that also comes out the next day and put in during surgery. You're going to begin some physical therapy. They'll come to your room 1 to 2 times a day. They'll make sure that you understand everything that's required. Pain management. We want to make sure that your pain is under control. And then education about the blood thinner that you're on. Now, the physical therapy, the pain management, and the blood thinner education, those are very important things. Those are criteria that we kind of watch for before we actually discharge you. There's equipment that you will receive. One of them is the wedge. You can see here it's a foam wedge that your leg rests on, and that's great for elevation for a knee replacement. If you're having a hip replacement, you do not receive the wedge. But you will have a wedge that fits between your legs to make sure your hips don't cross over after surgery. But that wedge is very important. I've delivered that wedge to people in the city because they forgot to take it. So take it home with you. I really believe in that for your elevation. The incentive spirometer, which is another big word for saying your breathing machine. It's just a little machine that's plastic that you breathe in and out, and it keeps your lungs open and keeps you coughing and prevents blood clots or pneumonia. Take it home with you. Your walker. We've asked you to come in the hospital with a walker, but we also want to make sure when you leave that you have the walker. Now, I say to the patients, if there's things that you're using while you're here, you're using it because it's best for your recovery. We want you to use it. So take it home. You paid for it. And use it at home because it's going to help with your recovery. But we do ask you to leave our TVs and our VCRs because we do want those. After surgery, home discharge. So once again, someone will come in to talk to you about home discharge. Allison will come in and talk to you about the agency who's coming in. We want to make sure that there's going to be someone home with you. And that nurse and physical therapist will come to your home 3 times a week for 3 weeks. The nurse that comes to your home is taking blood to make sure your Coumadin is on the right level. The therapist will be working with you, make sure you're progressing every day. If you have a home health agency that you're working with now and you really like them, let us know because we can identify who they are and we can make sure that they continue with you. Look around your house. All those little rugs that look so nice, take them away. They have problems that you could possibly trip on them. They're obstacles for your rehab. So take away the home things that might be a hindrance to your recovery. So aftercare for rehab discharge. Like I said, you'll talk to Portia, and Portia's number is there, and then she can help identify with some of the home health agencies, the nursing home rehabs that we use. There are some that we prefer, and we will work with you with them. We ask you to visit those facilities. Look at how big it is. Is it clean? Are you comfortable there? Do you feel safe there? Do the patients like the food that they're eating? Those are important things. And maybe have 1 or 2 choices for us. Time in rehab is 5 days to 14 days. I had one gentleman who went there in the morning, he came home in the afternoon, because there are milestones that you have to reach. And once you reach those milestones, the rehab has to send you home, otherwise it's fraud. So we say anywhere between 5 and 14 is about the normal rehab length of stay. Some of the things that I want to talk to you now about what you can expect after surgery. Number 1, I want you to know that this is an enabling procedure, not disabling, which means we're going to make you better after surgery than what you are today. So that being said, this does not require that we hand out something for you for permanent disability. You'll have the 12 weeks off, and you'll also have a parking permit, a disability parking permit for 6 months after surgery, and we will give that to you. Now, some people at this point do have permanent parking. You can continue with that, but Dr. Lou won't increase that. But whoever you got the original one from, they could increase it for you. Driving, this usually is asked by all the gentlemen, when can I drive? So it's usually about 4 to 6 weeks. But more importantly than that, it's when you're off all narcotics for 48 hours. Because I know that there are a lot of people out there driving on Vicodin, which is a narcotic, and we'd never advocate that. But if you would get in an accident and they found out that you had a narcotic on board, you could be in big trouble. So no narcotics for 48 hours, and that's approximately 4 to 6 weeks. Now you will be on, the last medication you'll be on is Ultram or Tramadol. That is not a narcotic. It's a very good pain reliever. You can drive on that. You can't get your incision wet for 3 weeks. Now, if you're having a knee replacement, that's kind of simple. You can wrap it with saran wrap and still take a shower. Hip replacements is a little difficult to wrap the area. I don't care how you do it. If you use duct tape, saran wrap, anything that you can use, but you cannot get it wet for 3 weeks. Going back to work, 12 weeks. 12 weeks of physical therapy. The first 3 weeks will be at your home or at the rehab unit. And once you're released from doctor at that 3-week period, you can choose your own rehab where you want to go, the freestanding rehab. Now, we do have affiliation with ATI, and ATI has a program that they will come and pick you up and bring you home. Because you remember, you may not be driving at this point yet. So once you find out where you want to go for your rehab, your physical therapy, see if they have a drive program for you. Your appointments that you'll see doctor after surgery, the first one will be at 3 weeks. You'll see the nurse practitioner. The knee patients, they'll take out those staples because you will have staples. The hip patients, they'll just look at the incision. At 6 weeks, you'll see your doctor, and he'll take an x-ray to make sure everything looks okay. You'll see the doctor again at 3 months, and at that time, he probably will cut you loose and saying, you're doing great, come back at a year. But now if he feels like there's a little bit of concern, he wants to keep his eyes on you, he may have you come back again at 6 months, and we'll see you as long as we're feeling that we could help you along the way a little bit more. And then we like to see you every year for that replacement. Other things as you can expect, reduced pain. We're going to make you better than you are today. You're going to have surgical pain, but we have all kinds of medications for that. But you won't have that bone-on-bone pain. Now I see a lot of people shaking their head. That bone-on-bone pain is what really hurts. And we're going to get rid of that with your joint replacement. You can expect no drainage or no bleeding. Once you leave here, there should be no drainage or bleeding come from your incision. If there is, I need to be called right away. Jennifer needs to be called right away. There should be no bleeding or drainage. That area that had surgery is going to feel warm, and it's going to feel warm for about a year. That warmth does not indicate infection. It indicates healing. Because your body is sending blood there. It's kind of bathing the area and making all kinds of good things happen to heal it. Swelling. You're going to have swelling. You had surgery below your belly, but you know you're going to elevate your leg higher than the level of your heart. Pain as you break scar tissue. Now this is for my knee replacement people. I think knee replacement people are heroes. It takes a lot of therapy to get great optimal benefits with a knee replacement, but the benefits are so worth it. What happens is your body, normally when it has an injury or sore, it produces scar tissue. So your body is making scar tissue in that knee area. So what you need to do is break the scar tissue. So you're going to be bending and straightening. I can't even tell you how many times a day. There's not too much. Bend it and straighten it, because when you bend it, you're breaking that scar tissue. Now, a lot of my folks say they had a wonderful therapy session. They go to bed, have a great night's sleep. They wake up in the morning and that knee is all stiff again. What happened during the night? Scar tissue developed, yes. So you almost have to go back to the beginning, but every day it's less and less. And after about 3 to 4 weeks, your body says, okay, I get it, and no more scar tissue is produced. I am done talking to you, and I think this is the end of the class. If you have any questions, I'd be willing to answer them when we're finished here. And thank you very much for your time.
For the swelling, do you also recommend ice?
Ice and